We are moving on to the next segment of this evening, which is on fertility preservation and oncology. We will be discussing on another vital topic on maternal oncology, which is cervical cancer in pregnancy. And Dr. Jayasree Gajaraj will be taking us through this topic. May I please invite Dr. Jayasree Gajaraj for the talk.
After a very nice lunch and exciting panel discussion, we move on to again probably a little bit of bread and butter. We are seeing more of cervical cancer in pregnancy nowadays. So let's discuss this as we go through. 1 to 3% of women diagnosed with cervical cancer, either pregnant or postpartum at the time of diagnosis. 50% of these are actually diagnosed prenatally, 50% in the first 22 months after delivery. And it's one of the most common malignancies in pregnancy itself compared to the others, but 0.8 to 1.5% of cases per 10,000 births. So it's not uncommon. We have primary concerns here because it's not just a woman with cervical cancer. The mother has a carcinoma. What is her long-term prognosis? What is the stage? What is the grade? We don't know what type of cancer it is. Fetus, what is the viability of the fetus? Can we salvage it or not? Because definitely the couple will want to have the child. So we need to respect their thoughts as well. Fortunately for us, many are diagnosed at an early stage, usually as a result of routine prenatal screening, which I think we should start doing. Most of us don't do prenatal screening for cervical cancer in early pregnancy. Booking visit is worth considering. Stage for stage, course of the disease and prognosis for cervical cancer in pregnant patients are similar to those in non-pregnant patients. So the onus is on us to look for it. Management is based upon evidence like RCTs in non-pregnant women, so that it's not going to be very different. And because we don't have very large series, large RCTs are not possible for this particular condition. Treatment is generally individualized, as with most situations, and it's based on the stage of cancer, woman's desire to continue, risk of modifying or delaying therapy during pregnancy, and how many weeks into her pregnancy she is. Clinical features, as I said, screening test usually is abnormal, and that's how we pick it up. Significant cytological abnormalities, but 5 to 8% in pregnant women, similar again to non-pregnant. The clinical stage and lesion size will determine the symptoms and signs that she presents to us with. So she may have, like any other cervical cancer, abnormal vaginal bleeding, intermenstrual, pelvic pain, sciatic type of pain. So you name it, a number of symptoms that are attributable. And again, diagnosis of cervical cancer may be delayed in pregnant women. She may have come to us with some spotting. It's not always that we do a speculum examination. Ultrasound is resorted to, which may not pick it up at an early stage. So there are a lot of pitfalls in our management itself, which may actually delay the diagnosis. Of course, if there's a gross cervical lesion, then obviously we are going to pick it up. So detection of early neoplasia by physical examination may be limited by normal pregnancy-associated changes. So even if we were to take a pap smear and send it, we need good cytopathologists who can differentiate normal changes in pregnancy at cytology as opposed to cytological changes attributable to a neoplasia. So we need to send it to the right person. Diagnostic evaluation, clinical findings, as always. The gross lesion, if it's suspicious, should be biopsied. Fear of bleeding should not deter us from taking a biopsy. Abnormal cervical cytology as non-pregnant. You can subject her to a colposcopy and take it forward. Important that we expedite treatment. Better not to sit on her. And when we do it, endocervical curettings, of course, not possible. Endometrial biopsy, again, you know that we are not at the stage where we can do it. Colposcopy has its technological problems because of the shear position and the direction in which the cervix may be pointing. So we need to be careful and we need to have a little experience in doing colposcopy in pregnant patients. As the pregnancy advances, the cervix is going to be pulled up a little bit more, and access or visibility may be limited. So we need again to have people who are experienced in doing colposcopy on pregnant women. So CIN1, cytologic and colposcopic evaluation postpartum 4 weeks after delivery, so we can wait. CIN2 and 3 and invasive disease is not suspected. Repeat the colposcopic evaluation every 12 to 24 weeks during the pregnancy or defer until after 4 weeks after delivery. So all this is after counseling the woman. And again, as I said earlier, colposcopy by a very experienced colposcopist. If colposcopy is unsatisfactory, repeat 6 to 12 weeks later, and you remember that the transformation zone would then have migrated, because we know that there is some degree of ectopy in pregnancy and eversion of the transformation zone. So if there is a suspicion, a repeat smear, repeat colposcopy may actually pick it up a little later. Cervical biopsies, we are afraid because she may have increased bleeding, but then we have ways of controlling bleeding. Definitely avoid diathermy as much as possible. Resort to Monsil solution if you can. And we have already discussed that immature metaplastic epithelium and reaction to the acetic acid, etc., it can mimic dysplasia. So repeatedly, good cytopathologist to give us the diagnosis. And whatever you may have found, if you are satisfied and if you are allowing her to continue the pregnancy, please remember that follow-up is essential. Repeat evaluation postpartum. Don't just let her go off. There is a role for diagnostic conization in pregnancy if confirmation of invasive disease will alter the time or mode of delivery. So yes, we can do it. We should not again say we may not. And it's postponed until the postpartum period to avoid potentially disrupting the pregnancy. If you feel it is indicated, you can go for a colposcopy and a colposcopy directed cone. The optimal time is between 14 and 20 weeks of gestation, and it should not be performed within 4 weeks of the estimated date of delivery for obvious reasons. Labor may cause fresh conization wound to hemorrhage or extend. So the healing process may not have taken place if she gets into labor. And remember, we're not going to do a cesarean just because we have done this. Pregnancy-related eversion of the squamocolumnar junction, which I mentioned earlier, it actually facilitates the conization. Sometimes, if you are not sure, you don't want to go for a cone, a limited wedge biopsy with application of acetic acid, defining the margins, can be done. And you can also do a cone cerclage. Cerclage is placed immediately after the cone, if you feel you have gone too high up. The potential complications of conization are hemorrhage, miscarriage, preterm labor, etc. And chorioamnionitis may sometimes set in, not very common, and then of course the ultimate intrauterine fetal demise. So having suspected, having made a diagnosis, we need to now know at what stage the particular disease is in. Only then can we realize or can we decide how we are going to manage it. So accurate staging, we need to counsel the patient, we need to plan treatment along with her wishes taken into account. Very, very important. The 2018 FIGO expanded the list of tests and procedures that may be used for assigning the stage. You remember in early stages it was purely clinical staging, and then they added on an IVP to it. So little things were added on. But now they're quite liberal with the imaging techniques that they have allowed us to offer to the patients. March 2021, the 9th version of the American Joint Commission on Cancer, they said TNM staging system was published, said that is probably a more accurate way of staging. So whichever method you are using, whichever method you are familiar with, go initially for a physical examination. You can do an EUA so that you can stage the disease clinically. You can add on imaging studies. MRI is something that can be used if it's going to help you to stage the disease. Chest X-ray, of course, with abdominal shielding, because you never know when you're going to get caught out with some mets in the lungs. Urinary tract has to be staged, because has to be imaged properly, because that will help us to determine the plan of action. Now, if you have a stage 1A, a microscopic or very small stage 1B that is less than 1 centimeter, routine radiographic imaging of the urinary tract can be omitted. So depending on what we find. But if you have a larger stage 1B1, bulky stage 1B2, risk histology, there is adenocarcinoma, small cell carcinoma, different from our usual squamous cell carcinomas, urinary tract should be imaged and ultrasound or MRI should be performed to rule out stage 3B disease. Extremely helpful for a patient when you're able to counsel her, and also it will help you to formulate a plan of action. So usually ultrasound and or MRI, mostly it's and it helps to evaluate the liver and the urinary tract at the same time, and it's not so much user dependent as ultrasound is. So remember, even ultrasound has a lot of pregnancy related changes in the urinary tract. So we need to be cognizant of that as well. Excellent tissue contrast can be obtained by MRI. It depicts all the pelvic anatomy in all the planes very clearly. You can calculate the tumor volume with this, and then you have, you can actually assess spread to the adjacent organs and lymph nodes. Just wait for him to finish his call. No, I think I'm disturbing his call. I'll just wait. Thank you. So what about lymphadenectomy? Lymphadenectomy actually help us in the staging or management plan. Certainly it does. And lymphadenectomy can be performed during the pregnancy. Selected patients who desire to continue their pregnancy but who are at significant risk of lymph node metastasis, it can be performed as a diagnostic procedure. Staging lymphadenectomy, again, usually an extraperitoneal or a laparoscopic, so the rest interference within the peritoneal cavity itself. Patients who are diagnosed with high risk, that is, those who are node positive disease, should be counseled about the importance of initiating immediate definitive therapy. So these are not candidates where we can wait on them. Endoscopy, again, staging procedures like cystoscopy, proctosigmoidoscopy, as indicated, they can be done, but not as a routine. We then have the stage, we know how many weeks pregnant she is, we have a little insight on the pathology, we know the lymph node status, how are we going to manage her? Stage of the disease, type of tumor, gestational age, up to 22 weeks, it differs from what we would do beyond 22 weeks. Because in some countries, viability is defined as 22 weeks. Desire for the couple to continue their pregnancies, desire for future pregnancies, because cervical cancer does not mean she's not going to have children anymore. So it's usually a combined decision. So management of the pre-invasive disease, now it's usually deferred to postpartum period. You can very confidently tell her that we can wait. So re-evaluate, go in for definitive treatment 6 to 8 weeks following the delivery. Suppose you have pre-invasive disease high grade, then the risk of progression to invasive carcinoma during during the pregnancy itself is only between 0 and 0.4%. So again, we need not worry too much. Regression may occur postpartum, so give her time and re-evaluate postpartum. Then the route of delivery, actually, vaginal versus cesarean, there's not much of information on whether the rate of regression especially is influenced by the route of delivery or not. So we can actually use standard obstetrical indications for vaginal or cesarean delivery. Moving on to invasive disease, it's a major challenge to the patient, her family, and to us as well. Because we know it is a cancer, it's invasive, so can we or should we give her the right approach or the right management plan is something that we need to be sure of. So here comes our MDT approach, not only in obstetric care, but also in gynecology. Desires of the pregnant patient, her family, about what she wants to do with the current pregnancy. So as opposed to, you have immediate definitive treatment regardless of gestational age. When would we offer that? Documented lymph node metastasis, progression of the disease during the pregnancy as we are following her up, and patient choice to terminate the pregnancy. So early stage disease, radical hysterectomy with the fetus in situ and with preservation of the ovaries, because most of the time they belong to the age group when she needs to have her ovaries. Advanced disease, definitive treatment as in the non-pregnant patient. Before chemoradiation, advocate evacuating the uterus. And the fetus is more than 20 weeks of gestation, as this will avoid the possibility of non-lethal fetal exposure to potential teratogens. So it depends on the viability in the place where we practice. Stage 1A1, you can go in for conization. Cervical conization during pregnancy, significant morbidity and perinatal complications are to be anticipated. Stage 1A1 adenocarcinoma management is a little controversial. We need to individualize. Stage by stage, cervical adenocarcinoma treatment is similar to squamous cell carcinoma, and the prognosis is comparable, but the actual behavior of the disease itself is something we cannot predict to the same extent. We move on then to stage 1A2 and 1B1 tumor. The reported risk of parametrial extension is less than 1%, so that's good for us. Conservative surgical options can be offered like a simple trachelectomy or a large cone, but counseling the woman, of course, that if we go too near the internal os, we could have problems. Radical trachelectomy should be avoided if pregnancy preservation is desired, because the extent of dissection is going to be a little more. Stage 1, B2, B3, or even stage 2 offer neoadjuvant chemotherapy if no lymph node involvement is demonstrated on diagnostic lymphadenectomy, or if your imaging does not show significant lymph nodes. Alternately, what you can do is neoadjuvant chemotherapy without prior staging lymphadenectomy has been performed and can also be offered. Surgical staging should be performed 6 to 8 weeks after delivery. So whatever we may do, that follow-up is very, very important. Now the question comes up, how safe is chemotherapy in pregnancy? So can we actually offer neoadjuvant chemotherapy to these patients? Continue up to 34 to 35 weeks of gestation with a delivery planned for 3 weeks later. So usually stop it about 3 weeks prior to whenever you're planning the delivery. And the standard regimen administered to women with metastatic cervical cancer, as you would in the non-pregnant patient. Generally, cisplatin and paclitaxel are delivered every 3 to 4 weeks, up to 6 cycles. And this relatively favorable risk profile for the fetal, neonatal, as well as the maternal complications are no different from the non-pregnant. Suppose you have positive nodal involvement. You've confirmed on lymphadenectomy or suspected based on imaging, as I said, and they wish to preserve their pregnancies. Treatment options will be neoadjuvant chemotherapy or earlier delivery. As soon as you're comfortable with the gestational age for your NICU, then you deliver the patient. Don't sit on her for too long. Ethical and medical issues have to be kept in mind, because advanced disease characteristics, patient preferences, viability of the baby. Suppose you have a borderline viability, you deliver the baby, then you're going to be in trouble, because she's going to improve with your treatment, and then she's going to ask you, why did you not save my baby? So we know the odd questions can come up. So here again, MDT approach important, MDT counseling is important, and maybe if required, even video recording of the counseling has to be done. Now, particularly gestational age 22 to 25 weeks or later, as I told you, in many countries, 22 plus is considered as viable fetus. What do? Lymphadenectomy is less of an option here, because increased risk of surgery, size of the pregnant uterus itself can deter surgical procedure itself. Diagnosis on the treatment based on clinical stage of the disease at diagnosis. So you have to keep that in mind. So here, stage 1A and stage 1B1 tumor, where the tumor is less than 2 centimeters, suggest delaying treatment until 6 to 8 weeks after delivery. So you have to counsel the couple. Suppose you have a 1B2 or higher, and the tumor individual is more than 2 centimeters. We don't have enough data to support lack of data on treatment delay and outcomes. We don't know. So again, we have to tell her that, and if she chooses to take the risk and wait, you can wait, or otherwise proceed. Tumors which are more than 4 centimeters with or without positive lymph nodes, confirmed in either clinically or suspected, patient prefers not to deliver early, advocate neoadjuvant chemotherapy until delivery, but tell her that the prognosis is guarded. She has to be aware of that. During pregnancy, require follow-up for the disease progression itself if we are taking up the conservative approach. Surveillance strategy dependent on the extent of the disease. Women with stage 1A1 disease, a clinical examination and colposcopy in every trimester throughout pregnancy is enough. Women who elect to delay the definitive treatment where it was indicated, and those who have gone on to neoadjuvant chemotherapy, recommend pelvic examination every 3 to 4 weeks. Repeat MRI without gadolinium it should be performed to rule out any kind of disease progression. And then you need to get the maternal fetal medicine specialist on board because we need to know when that baby can safely come out. So evidence of disease progression, once you know it's there, then no longer you should wait. That is, during the pregnancy, you should go in for definitive treatment. The delivery itself, gestational age of the fetus, stage, whether the tumor shows any evidence of progression during the pregnancy will determine how long we are going to wait. Term delivery, you do not wait till 40 weeks, usually 37 completed weeks. If you are able to go on to 39 weeks, you should be able to. I think I have another 2-3 slides. Is that okay? Right. So cesarean section again need not be the norm. It should be reserved for standard obstetrical indications only. Episiotomy is better avoided because 15 cases of tumor cell implantation at the episiotomy site has been reported. So we need to be careful. If you have a 1B stage or a little greater than that, better to avoid vaginal delivery. The bulky or friable tumor, barrel-shaped cervix is sometimes we have seen. All these are at risk for significant hemorrhage and obstruction. So unnecessarily we'll find ourselves in a mess. Better to plan elective cesarean for these patients. And prudent to schedule a cesarean section once a fetal maturity has been reached. Are we worried about the vertical transmission? Maternal transmission of cervical cells to the placenta and or the fetus is rare, but the mechanism of spread usually transplacental and or aspiration of tumor contained in the fluids. All these have been postulated, but it's very, very rare, so we don't have to worry too much. So once she has delivered, then definitely plan definitive treatment. Here again, you need to look at the stage now as opposed to when we made the diagnosis. If she wants to preserve future fertility, then you would again offer her a cone, a trachelectomy, etc. But if she has completed her family, not keen, then as indicated, you can go for a more radical procedures. Stage 1A1 with LV, that is lymphovascular space invasion, 1A2 or B1, neoadjuvant chemotherapy, and metastatic disease outside of the cervix involving other organs like liver, lungs, stage 4 cervical cancer. You know the prognosis is poor irrespective of your management. So a lot of psychological and emotionally it's very difficult for the patient and for us as well. So you should individualize and take the case forward. So it's very, very not uncommon, we are finding it. It's just that we are not diagnosing it often enough. So my only take-home message would be, I think where possible, try to do a pap smear at booking. And if you do find it, refer the patients to somebody who's regularly taking care of them. Do not just reassure and follow up the pregnancy. A colposcopy or some kind of imaging definitive diagnosis is definitely indicated. Thank you very much.
Thank you, Dr. Jayasree Gajaraj, for the impactful session.